Our first speaker for this segment will be Dr. Abhishek Shinde, who's going to be talking on the ROSA.
Good evening, everyone. Thank you, Venkatesh, for giving me an opportunity. So, this you can do the image-less as well as image-based. We are hearing since morning. Just quick rewind. Image-based, you have to do the pre-operative scanogram in AP and lateral. This is the position. Your X-ray technician should be trained very well to get these images. Then you can register for the imageless, you can register the case and straight away go for the planning. This could be a possible OT setup we have seen in the live demonstration by Dr. Ashok Suryavanshi, the ROSA on the same side or ROSA on the opposite side. In bilateral cases, you can adjust as per your convenience. These are the basic steps for ROSA robotics. You have to do the registration mapping, that is bone morphing, plan verification, guided cuts, validation, adjustment, component positioning, revalidation, and the balance through the simulated range of motion. So ROSA positioning and alignment of the ROSA, just pictorial. ROSA registration, I'll go through quickly this video. So tracker placement, all has been, it's 3 cortices. You don't have to breach the 4 cortices, 4 finger above and 4 finger below, preferably on the metaphyseal area. Then the landmark registration, femoral head center, femoral canal entry, posterior condyle, anterior trochlear groove, posterior trochlear groove, which match the white side line. Then the posterior trochlear groove, medial epicondyle and the medial distal condyle, lateral epicondyle, transepicondylar axis which forms, and then the anterior cortex. For the tibia, to demonstrate both the malleoli, medial third of the tibial cord, tibial canal entry, PCL insertion, medial plateau resection, and lateral plateau resection. Lateral plateau has to be more in this. To get this, you have to give the anterior translation to get the landmark correct. This is the landmark registration, just a demonstration of the video. Then you have to evaluate the knee, how much amount of the flexion of the varus you have in throughout the range of the motion. In full extension in 30 degree, 45 degree, 60, 90 and 120. Once you are happy with that, you can do the planning, how much about the distal resection or proximal resection, how much amount of the varus or valgus, the stylus height, the posterior slope, and then you can take the guided cuts. So this is the varus knee. You have to balance on the lateral side, preferably 19 mm both, and flexion and extension. Once that is done, you can do the distal femoral cut. The distal femoral jig will come and sit in the first is automotive and then collaborative mode. Once you are happy with live cuts value, you can take the cuts and then you can revalidate it. Just again a proximal tibial cut. Then the jig will come and sit automatically, and you have to just confirm whether the live cuts values are okay, and then do it. This 4-in-1 jig. So once that is done, you have to see the live cuts value, and then you can go through the trial and then see the post-op, how much amount of the varus correction or this thing you have achieved on table. So these are some of the cases. You can go through this. You can do the varus with stress fracture. You can do the valgus knee. This is case 1 with the stress fracture. The morning there was a lecture where you have to take out the tracker pin, particularly tibial tracker pin. This is the one condition which the tibial tracker pin has to come out before the final before the tibial preparation, because the patient had the stress fracture. This was his post-op X-ray. Again, the bilateral knee replacement you can do pretty well with this ROSA robotics. This is the scanogram post-op. This is case 3. Again, the severe varus deformity. Earlier it was operated by without navigation. This I operated with navigation. This is case 4. Again with the tibial varus and the stress fracture. This is the scanogram on the lateral view, and this is the post-op X-ray. This is the valgus case, extreme valgus, which I came across. This was almost 22 degree of the valgus, but it was correctable. But along with the valgus, she had the recurvatum deformity as well. This is her post-op X-ray. So what we're learning and we are repeating since the morning, it is the learn, adapt and evolve. So that's what the robotics means is. So I thank you for patient listening. This is just on sweet note. I remember when this movie came, does this happen with robotic as well? So I thank you for patient listening. Thank you.